All right, we'll go ahead and get started then. Good morning, everybody. It is my distinct pleasure to introduce Dr. Kelly Knupp. She is a professor of pediatrics and neurology at the University of Colorado and director of the Dravet program at Children's Hospital Colorado. You know, um, it has really been kind of my distinct pleasure to know Kelly. Many of us hope when entering neurology that we'll have a significant impact on our field. However, very few of us will ever achieve this. But I think that Kelly is one of those people who can make this claim, and rightly so. She's really had a significant impact in the way that we think about the treatment of disorders such as infantile epileptic spasm syndrome, pioneering, research and a clear protocol about how to treat, which we've actually implemented at our institution and has been implemented at many children's hospitals across the country. In addition, she's been a driving force and creator behind the Pediatric Epilepsy Research Consortium and was its president for many years. A lot of that was because she couldn't seem to find anybody to take it over, but it has now grown into a giant consortium that has 75 different epilepsy centers with 60 ongoing research projects. It's really trying to position itself to be a resource for the creation of new studies and different areas of research. And I know she was an incredible resource for me, particularly in the area of Dravet syndrome, which she will be discussing in more detail today. So, Kelly, thank you for joining with us.
Oh, Kevin, that was so kind and flattering, and I'm not sure I can live up to that. I'm
You
I'm
will.
just a girl who likes to work with other people. So, but thank you for inviting me to speak today. I'm excited to talk to you about my favorite topic, which is Dravet syndrome. And I was challenged with giving you updates for Dravet syndrome in 2024. And there's a lot of exciting things happening in Dravet syndrome, but a lot of them are still in evolution. So I hope I'm able to teach you a little bit about Dravet syndrome and some of the things that I see and do in this syndrome. So. Let me get for some reason my slides aren't advancing. Okay, I think I'm in better control now. I do have disclosures. I do have research funding, much of which is related to Dravet syndrome. I also do consulting, which is also related to Dravet syndrome. And I'm on the DSMB for Jazz Pharmaceuticals and Epigenics, which I think is recently just turned into Harmony. The I don't think it impacts what I'm presenting to you today. Hopefully everything is fair and unbiased. Our objectives for today, I hope that you'll understand non-seizure related symptoms of Dravet syndrome, that you'll be able to review treatment options available to treat Dravet syndrome now and in the future, and also review challenges of transition into an adult model of care for patients and families living with Dravet syndrome, which I think is particularly challenging because many of our adult colleagues um, don't actually think that they see patients with Dravet syndrome, or at least that's what my adult colleagues have told us here in Colorado. So it makes it really challenging to transfer our patients into that adult model of care. So just to kind of give a brief snapshot of Dravet syndrome, and I'm sure many of you know this, but this is an early onset, lifelong drug-resistant epilepsy. The vast majority of people with Dravet syndrome, which is a clinical diagnosis, are related to pathogenic variants in SCN1A, resulting in a haploinsufficiency of a sodium channel NaV 1.1. And this is located predominantly in GABAergic interneurons. This haploinsufficiency is incredibly important because that's actually allowing us to leverage the good gene. Haploinsufficiency means you have one gene with a pathogenic variant and one gene that's functioning. So it gives us options when we think about gene modulatory therapies. And then there are a lot of significant comorbidities associated with Dravet syndrome, intellectual disability, behavioral changes, sleep disorders, a crouched gait, and a very high risk of SUDEP. I think it's important to recognize, and I'll talk a little bit more about this, that some of these morbidities actually evolve over time. And so you're not going to see all of these things right at the beginning. And most important is to recognize that intellectual disability usually is not present in the first 1 to 2 years of life. And we've seen lots of children who were told that they looked too good to have Dravet syndrome when in fact they had classic Dravet syndrome. The ILAE has recently created some criteria for diagnosing Dravet syndrome. I think it's always important to keep in mind that when ILAE does this, first of all, it's done by group and consensus, which I think is really important to get people's input. But it's also meant to be applied worldwide, including countries where genetic testing may not necessarily be available. There are mandatory things in the diagnosis, having focal clonic or hemiclonic febrile and afebrile seizures, focal to bilateral tonic-clonic or generalized clonic seizures that happen both with fever and without fever. No diag Things that should be a little suspicious is if there's no history of prolonged seizures, although it occasionally happens. And lack of fever sensitivity as a seizure trigger is an alert. I will say I had one or two patients where, for whatever reason, they otherwise have classic Dravet syndrome and don't have seizures with fever, which is kind of weird and unusual, but it does happen. It is very unusual for children with Dravet syndrome to have epileptic spasms. And that actually should alert you that there's probably something else going on. And the ILAE went so far to say that that would be exclusionary. Most of these children have normal EEGs, but if they continue to have a normal EEG after the age of 2 years of age, that's unusual. So those initial EEGs may look normal unless they're having seizures, but progressively they do become somewhat abnormal. We usually see age of onset between 1 to 20 months of age. Onset prior to 1 to 2 months of age is pretty unusual, and we should be thinking about other causes. And then onset after 15 to 20 months of age is also unusual. Developmental delay at seizure onset is unusual in this patient population. Usually we see that evolve somewhere in the second year of life. These children can have Todd's paralysis, but having other focal neurologic findings outside of having a seizure is somewhat unusual early on. We definitely can see changes later on. The vast majority of these children have normal imaging, although having particularly children who've had multiple episodes of status, we may see progression of MTS, but it doesn't usually explain all of the seizures that the children are having. But if we see a causal focal lesion and it explains all of the seizures that the children are having, that is unlikely to be Dravet syndrome. And most of these children, of course, have a drug-resistant epilepsy and intellectual disability. So who should we think about testing? Genetic testing is something that we do much sooner and is much more readily available. I hope that you have access to genetic testing as easily in Arizona as we do here in Colorado. And so, many of our patients are getting tested after a first or second seizure. The recommendations from a Delphi consensus project is to test after a single prolonged hemiclonic or focal to generalized seizure in the setting of fever or vaccines. So we don't want to test everybody who has a febrile seizure, particularly if it's a simple febrile seizure. But if it's a prolonged seizure with some focal nature to it, it would be very reasonable to think about testing that patient. If we see recurrent prolonged focal or generalized seizures with or without fever is another situation where you would think about testing. And if you see recurrent brief hemiclonic seizures with or without fever, we would think about testing those. So we're really suggesting early testing, and part of that is because it really will change early management, which may actually have a significant impact on outcome in the long run. The problem with SCN1A is it actually is a large gene. And so as you know, and the problem with genetic testing is many times we get results back that we're not always sure what to do with it. And this prediction model has actually been particularly helpful. This is from the Broad Institute. Quite honestly, you can actually just Google SCN1A epilepsy prediction, and you will find your way to this website. And this will give you a good idea of whether you expect to see Dravet syndrome or GEFS plus, or if it's a non-concerning variant. So an excellent resource that Andreas and his team has put together, which I think everybody has been using more and more, and potentially will be very, very clinically important as we move into the future, if gene modulatory therapies become available before we can see the full progression of Dravet syndrome. Well, I seem to have lost control of my slides again, but I'm back. I'm not sure what happened there. The other thing for us to keep in mind with SCN1A is that we can see gain of function clinical presentations, and these have been divided up a little bit into a couple of different groups. But the hallmark really of these are very early seizures, usually within the first days or first couple of months of life, and then also a movement disorder that's associated with this. Um, uh, there's the neonatal developmental and epileptic encephalopathy with a movement disorder and arthrogryposis is exactly what it sounds like. It's very early onset of seizures. There's congenital arthrogryposis. Tonic seizures tend to be prominent, as well as apnea and a movement disorder that's pretty prominent and is early on in life, as well as profound intellectual disability. These kids do also have status epilepticus. The reason it's important to recognize this is that for most of our patients with a pathogenic variant in SCN1A, we would stay away from sodium channel blockers. But for these children, actually high doses of sodium channel blockers may be very helpful for them. We also see an early infantile epileptic encephalopathy with movement disorder. The difference with this variant is we see a similar clinical presentation, but a little bit later. It's usually in the first couple months of life, not in the first couple days of life, and we don't see arthrogryposis associated with this. And again, response to sodium channel blockers. So we're going to treat these children very differently. I think it's also to keep in mind that variants of SCN1A have also been reported with familial hemiplegic migraines. And so if you're seeing somebody who has a seizure disorder and has SCN1A, but it doesn't really seem to fit Dravet syndrome, this may be something else to talk to the family about, particularly if you see that variant if you have a history of migraines or see the variant in family members. You may be dealing with something that's a little bit different. I mentioned earlier that Dravet syndrome has an evolution, and I think most people are probably familiar with this. But this is, I could probably, just use this slide to talk about everything associated with Dravet syndrome. In the first year of life is when we see prolonged seizures, usually in the setting of temperature changes. And that's things like vaccines, that first illness, but it's also other temperature changes. And some families may or may not talk much about this, but it's important to ask them. They may see seizures getting in and out of the bath. With rapid temperature change. When you walk into the grocery store or a big box store and they have that blast of heat at the entrance, that has been a trigger for some of these families. So really important things to talk to families about because they may actually alter some of what they're doing. When I've started to ask families who have noticed seizures with the bath, I've actually learned that families stop bathing their children. And so we need to come up with strategies to try and make that work. After 12 months of age, usually between 12 to 4 years of age is when we start to see other seizure types emerge, and pretty much every seizure type emerges except for infantile spasms. So you can see tonic seizures, you can see drop seizures, you can see a lot of myoclonic seizures. You can see a lot of eyelid fluttering that may or may not have an EEG correlate. I suspect that that is focal myoclonus that we're seeing with that because it doesn't always have an EEG correlate, which doesn't always make sense to me. This is the time period where I used to meet my patients in the ICU because they would go into status, very prolonged episodes of status. Fortunately, with some of our newer medications, we're able to avoid those frequent episodes of status. And then somewhere between 5 and 8 years of age, we start to see shorter seizures. Those seizures generally are either hemiclonic or generalized tonic-clonic seizures, and they start to coalesce at night. And we'll start to see clusters of seizures at night, which is a bit of a mixed blessing. It means that children are safe during the day. We're unlikely to see seizures during the day for most of our patients, but they may have a number of seizures at night. there's this really bizarre phenomenon where the kids seem to, for the most part, do okay with lots of seizures at night. Um, so they may have, 10, 20 brief generalized tonic-clonic seizures at night, and then they pop awake in the morning and they're just fine and functioning okay. A lot of families will actually stop using rescue medicines for these clusters of seizures because they find that they see more side effects related to the rescue medicine than they actually see when their children have seizures. But the parents are exhausted because they're having to monitor seizures at night. So it's kind of a mixed blessing to see that. We also can see uh, ataxia emerge. Here in this graph, it comes out around 12 months of age, which coincidentally is when kids are walking. I see prominent ataxia in toddler ages. It seems to get a little bit better and then gets worse as the kids move into school age. So I think it's a little bit more biphasic than what this represents with this brown line here for ataxia. SUDEP is really pretty static. The risk of SUDEP is pretty static across the lifespan. So this is, we always think of SUDEP as greater risks as we get older, but for our patients with Dravet syndrome, it's just always a risk and something we need to make sure that we talk to our families about. Gait abnormalities and development. So development is typically normal at onset. We usually start to see delays in the late preschool, early school years. I will say with better medication, I actually have a lot of patients who do hit kindergarten with all of their kindergarten readiness skills. They know their letters, they can put sounds to their letters, they can count to 30. They're doing the things that we would expect a kindergartner to do. And then things will actually get worse. Typically will plateau after that, which is really important to let families know about. True regression is rare, but we do see that this failure to acquire new skills. Having said that, we sometimes do see regression with episodes of prolonged status. But by adolescence and adulthood, most children have a moderate or greater intellectual disability. We also see this gait abnormality where we see flexion at the knees, a stooped posture. This is pretty characteristic of a teenager with Dravet syndrome and something that is somewhat characteristic for these families. I think, the families actually call it a crouched gait. And we usually see it in later elementary school years and adolescence. This will continue to progressively get worse as these children move into their adult years. So it's really important to prepare families for this. It seems that one of the most helpful things is actually continuing to exercise. In the past, people used to try to operate on their ankles to try and straighten out their gait. It turns out taking them off their feet to operate on their ankles is probably not helpful. And many children may not return to ambulation when that happens. So we really, really discourage any orthopedic surgeries for this because it just doesn't seem to be helpful in the long run. One of the things I tell families is, as much exercise as they can get, it will be super helpful. I recommend that families not send their wheelchairs or their travel chairs to school. School always wants them because it takes them a while to ambulate around. But that once we send those to school, they stop walking at school, and then that impacts the rest of their gait after that. I have a number of families who actually stopped using the bus to go to school, and they will actually walk their children to school to get exercise for them. The other thing that has been helpful, and there's really no data, no published data on this, but Cinemet has been helpful in a number of these patients. They do seem to have a little bit of cogwheeling rigidity. They generally don't have tremor. Whenever I see tremor, it's usually patients who are on Depakote, and it doesn't seem to be a Parkinsonian tremor. But we actually do see improvement in gait, not full correction of gait, but improvement of gait with Cinemet. And so that's something that can be particularly helpful. Behavior is a huge problem for these kids. Inattention and hyperactivity is reported in 70% of the kids. Perseveration is a huge issue, reported in about 50% of the kids. And that actually is something that gets worse as the children get older and can have significant issues. One of my patients perseverates on cheese. Anytime she's in the kitchen, she demands to have cheese. She will throw a temper tantrum. It can go on for hours. And so family will often give in to give her cheese just for quality of life. But she gets admitted to the hospital for constipation because sometimes she only eats cheese, and that is not a healthy thing to eat. Um, the A lot of the children do have issues with poor appetite and eating difficulties. I actually think this has to do with coordination of their mouth movements and chewing. A lot of the kids like to eat soft foods. Oddly, they like to eat really spicy foods. Most kids with Dravet are relatively pain intolerant, and so I think spicy foods are interesting to them because they're not as uncomfortable with spicy foods as other people. Uh, but when I talk to families between their inattention and their difficulty chewing, some families are spending over an hour feeding a single meal to some of their children. And so that's the time period when we think about, do we need to supplement with a G tube, just so that they have a additional way to feed them and they're not spending 5 to 6 hours a day simply trying to feed and nourish their children. We do see reduced height and weight growth trends with age. So as the children get older, they do tend to be more on the petite side. It's really important to look at both height and weight whenever you're trying to assess whether somebody is malnourished, because if their height is less than the fifth percentile, then we would expect that their weight would also be less than the fifth percentile. So important to keep that in mind. Sleep is a huge issue for a number of children with Dravet syndrome. And as you know, if a child is not sleeping, the rest of the household is not sleeping as well. And behavior and sleep are the two biggest quality of life issues that families will report, second to seizures. Some of our older data, there were sleep studies done in 6 children with Dravet syndrome, and they reported no abnormalities. It turns out that's probably not true. In surveys done by both the Dravet Syndrome Foundation and by me, we found that 97% of parents had concerns about sleep. It doesn't really change with age. Parents, about 30% of parents are reporting apnea. 65% of parents report that their children have difficulty falling asleep. Another 70% report that their children have difficulty waking from sleep. That tends to be one of the most common things that I hear, is that children wake up at 2 in the morning and it's just like a party in their room at 2 in the morning, or having short duration of sleep. So lots and lots of sleep issues. Here we have some additional data about sleep issues. So again, 43 out of 57 children reported sleep problems. And again, this had to do with, you can see it's kind of across all the ages. That's really what I wanted you to hear, to see here. And it has to do with sustaining sleep, initiating sleep, and those types of things. Curiously, only 6 of 16 had abnormalities with home oximetry testing. So it's not really sleep apnea that they're having struggles with. It's actually just getting to sleep and sustaining sleep that we're largely seeing. For 59% of families report co-sleeping. This actually has more to do with concern for seizures and SUDEP at night. Again, I talked about seizures as the kids get older tend to coalesce at night. And so many parents feel that they need to monitor what their children are doing at night. The seizures do disrupt sleep in about 48% of people, but 76% of families reported non-seizure sleep disruption. So that's something that we can actually try to do something about. We do recommend good sleep hygiene, but the truth is many families are doing this. 72% report that they do bedtime the same time every night. 70% of the children fall asleep within 30 minutes. So sleep hygiene isn't enough to fix some of these issues. There are not great studies about what to do, but I do have some tips here that many of us in the Dravet community will use. So I usually start off with melatonin, particularly if the issue is getting to sleep at night. It seems like a little bit more natural way to step into addressing sleep. But I think it's really important to keep in mind that this really only helps getting children to sleep at night. It doesn't help if they're waking up in the middle of the night and having a party in their room. So clonidine is usually what I will go to if I'm hearing arousals in the middle of the night. We know that clonidine increases the amount of REM sleep. It can also decrease sleep latency and decrease arousals. It is important that this is off-label use of the medication. It does also help with inattention, which can be very helpful for these kids as well. So that's usually my go-to when I hear about awakenings in the middle of the night. Trazodone is something that can also be used. There is a little bit of data that trazodone can also decrease seizures. Scott Barabon has reported that in his zebrafish model. I will say clinically, I very rarely see that trazodone decreases seizures, although I do have one patient who had a significant reduction in seizures with the use of trazodone. But that's, one person. But something that may be helpful, and it's important to watch out for. Quetiapine is used by some as well to decrease sleep latency and prolong the duration of sleep. So that can also help with the decreased arousals. Again, there are no treatment studies that are specific to Dravet syndrome related to this. And some of this is very much off-label use of medication. So important to keep that in mind. Vaccines are a challenging discussion for families with Dravet syndrome. I think it's really important to recognize that most of our families are not vaccine hesitant. They're actually status epilepticus hesitant. When your child had an episode of status the first 2 times they received vaccines, you kind of don't want to keep doing that again. And I think that that's really important. There is on social media still a handful of families saying that vaccines cause their child's Dravet syndrome, which is not true. And we actually know from data that there's no difference in long-term outcomes in children who present with seizures related to vaccine compared to those without. But this is the lived experience of some of our families. And with social media, you get to share all of those things. The One of the things that we really do try to encourage is flu vaccines for our families. And there's actually some data suggesting that flu vaccines are very helpful for our patient population. So there's a study that looked at 26% of patients in a single cohort that had documented flu. 54% of those with flu presented with status epilepticus. 21% had a seizure exacerbation. There was one death due to a respiratory failure. 3 had significant respiratory complications, and 2 patients with cerebral edema. So, this is much more disease than we would expect to see in the typical population with flu. And so I think this is evidence that flu vaccine is particularly important for our patients. Some of the suggestions that we use for our patients for vaccine is using antipyretics for 24 to 48 hours surrounding the vaccine. I usually recommend that families actually take their first dose as they go into their pediatrician's office to get the vaccine. For some of our families, we will also do benzodiazepine surrounding vaccine administration. You can do a clonazepam bridge. If they're already on clobazam, we can go up on their dose of clobazam for 3 or 4 days to try and give them protection. Again, I usually have them start this the morning that they're going to get their vaccine. So we already have something on board around the time that they're getting their vaccine. We do also recommend that we vaccinate all of those in contact with a person with Dravet syndrome, including family, therapists, and school. A number of my patients actually have this written into their IEP, that their therapists and their teachers at school and their paraprofessionals are all required to have now flu and COVID vaccines. And many families have been successful in having that written in. An interesting thing that a number of our families have started doing is they actually delay their school start by 15 minutes so that the teacher can assess the classroom for illness. I thought this was a really interesting approach. So, if there's a lot of children in the classroom that are sick, they will simply do school at home that day instead of going into school. Not sure I'm thrilled about that because it's keeping kids out of school. And if you've ever met a child with Dravet syndrome, they are incredibly social kids. So I'm not sure that this is in their best interest of their education or their social needs. But I do think it is an interesting thing that can be done, particularly, perhaps if it's a small classroom and you're less likely to see kids who are sick. So let's change gears a little bit and talk about therapy. So there are three new medications, relatively new medications, cannabidiol, fenfluramine, and stiripentol, which I'm sure you're mostly familiar with for use in Dravet syndrome. We also have a couple of medications in trial, in addition to some of our gene therapies that are in trial, including clemizole, bexicaserin, and soticlestat. Soticlestat just completed their trial, and they aren't, their p-value was 0.06, so they're sort of hovering on being statistically significant. And they've been in discussions with the FDA about how to move forward with that. But let's look at some of this data, and I'll go through it fairly quickly because I think that you are familiar with this. The cannabidiol trial for Dravet syndrome was statistically significant with a reduction of seizures from 12.9 to 5.9 median seizures per month. And so they met the primary endpoint and is FDA approved for this. Fenfluramine, you've probably seen these before. I think you can see my pointer, but if we look at the 50% reduction in seizures, we see with high dose, 68% of people had a 50% reduction of seizures with high dose fenfluramine. 38% had a reduction with low dose fenfluramine. So low dose fenfluramine works for some patients as well. Whereas placebo, it was a 12% reduction of seizures. 12% of people had a 50% reduction of seizures. What I think is particularly interesting is that if we look at patients who had a 100% reduction of seizures, we actually see that there were some patients who got there on both high dose and low dose fenfluramine. And we don't see that very often. The I also think it's important to kind of look at how the study was designed, particularly as I'm going to compare this to stiripentol. With fenfluramine, we looked at convulsive motor seizures. So it was any seizure that had a motor component. So they were generalized tonic-clonic seizures, a tonic seizure, a focal seizure that had a motor component. So there were a lot of different seizures that were actually counted towards the endpoint. The myoclonic seizures and absence seizures were not counted towards the endpoint. But still, to see patients who were seizure-free or nearly seizure-free was pretty impressive. And here, this is looking at it in a slightly different way. This is looking at the number of the percentage of patients who were seizure-free or nearly seizure-free. So this included people who had one seizure or no seizures during the trial time period. And we actually see that 25% of patients were seizure-free or nearly seizure-free with fenfluramine, which is pretty exciting. And even in the low dose, we saw it was, around 14% that were seizure-free or nearly seizure-free. And we just don't see that very often. So that was really exciting about this medication. Stiripentol, which had initially been studied in Europe and then eventually was brought to the US without a new study, which was kind of interesting. Also reports seizure freedom, a shocking amount of greater than 40%. But I think it's important to keep in mind their primary endpoint was generalized tonic-clonic seizures. So they didn't count all those other seizure types. They were just looking at big generalized tonic-clonic seizures. But we do still see an impressive amount of seizure reduction and an impressive amount of seizure freedom, although I don't think you can directly compare to what was done in the fenfluramine trial. Stiripentol is a little bit tricky to use. There's no evidence to support the use of stiripentol as monotherapy. It was in Europe, Canada, and Japan. It's licensed for use in combination with clobazam and Depakote. Here in the US, it's FDA approved only for Dravet syndrome in combination with clobazam. It's also important to keep in mind that it actually has impact on the liver and alters how other medications are metabolized. And so we typically have to decrease clobazam and Depakote. In my clinical practice, whenever I'm adding in stiripentol, I'll reduce everything except for Keppra by 50%. Whenever I add in stiripentol, Keppra is not metabolized by the liver, but virtually all the rest of our anti-seizure medications are. So important to make those adjustments. Otherwise, you will see a whole ton of side effects and families won't be very happy. The initial data that we saw for soticlestat and Dravet syndrome was impressive, where we actually saw a 36% reduction in seizures. and placebo actually had a 10% increase in seizures. And so people are pretty excited about this. They have gone on to, they've just completed their phase 3 trial, which, as I mentioned, is like just barely not statistically significant at with a p-value of 0.06. And so they are in discussion with the FDA, and we're not really sure what's going to happen with this product. So this product may or may not come to the market, or potentially we'll see other studies for this product. So not really sure what the future of this product is going to be right now. Adalurin is a medication that's been around for a while. I sort of feel like Adalurin is a drug that's trying to find its disease. It increases protein expression by reading through premature stop codons. And Oren Davinsky and his group treated 7 patients with Dravet syndrome. And unfortunately, for cognitive outcomes, there was no change. They looked at the BASC, BABS, and QALC. Also, no change in seizures associated with this. No significant change in seizures associated with this. So this is something that is on the market and can be used, but there really isn't great data for this. I don't have a slide for bexicaserin, but I do just want to mention bexicaserin has a mechanism of action that is similar to fenfluramine and but is more potent than fenfluramine and is less likely to have cardiac issues and is just about to enter into phase 3 trials. They did have a broad DEE basket trial, which demonstrated some efficacy. I think there were only 3 or 4 patients with Dravet syndrome in that. And I suspect you guys may be participating in those trials as well. They have both a DEE without slow spike and wave and a Dravet syndrome trial. So we'll have more data about that in the future. It's hard to manage all of these medications that are available, but through a Delphi process, we have some recommendations about what to do for Dravet syndrome. And first-line therapy is currently recommended as valproic acid. Second line is fenfluramine, stiripentol, or clobazam, moving on to cannabidiol, and then topiramate and ketogenic diet, and particularly noting that we need to stay away from sodium channel blockers. I will say in my own practice, most of my patients who are newly diagnosed with Dravet syndrome come to me on Keppra. So Keppra seems to be the de facto first line for most of our patients. And then we will move on to valproate. I would personally not be opposed to using fenfluramine in these patients, but it's not approved for children under the age of 2, making it really, really challenging to initiate it. I've only been successful in having insurance pay for 1 patient under 2 years of age, and that was after the family had used it and paid for it out of pocket for 4 months and demonstrated its efficacy, which was a little bit unfortunate. But it was well tolerated in that patient population. In the children under the age of 2. I have no reason to think that it wouldn't be. We do know that contraindicated medications can cause problems in people with Dravet syndrome. These are some older studies out of Europe, but looking at 164 children with SCN1A related seizures, 116 with Dravet syndrome, 86% had been exposed to contraindicated medications, carbamazepine, oxcarbazepine, phenytoin, lamotrigine, vigabatrin. And they found that there was a clear correlate with the use in the first 5 years of life and cognition. The longer duration somebody was on an inappropriate medication correlated with a lower developmental quotient. So this does not really include patients who've only been on it for 4 or 5 weeks and somebody quickly realized that this was making seizures worse. Most of these children were on these medications for months to years. But this is another reason why it's really important for us to make that early diagnosis. And then the alternative question is, do early effective therapies help? And when stiripentol was coming on board, a French study looked at patients who were started on stiripentol before 15 years of age or after 15 years of age, and actually found that neurocognitive outcomes were better in those who were started on stiripentol before 15 years of age. And this was independent of using inappropriate medications. I will say most of our patients are started on stiripentol before 3 years of age at this point. So hopefully that's making some impact on the cognitive outcomes that we see in our patient population. So let me move on and talk a little bit about gene modulatory therapies. Uh, the and I'm sure you guys are following this as well, but um, it's a really exciting thing to see. The hope with gene modulatory therapies is that we can address the whole syndrome rather than just single symptoms. Most of the data that I've presented to you today has been related to seizures, unless we're talking specifically about sleep or behavior or gait. And so this is a way that we can address all of the symptoms that we see with Dravet syndrome. And, in an ideal world, earlier treatment is likely to lead to greater improvement. We're not quite there yet, but it's going to make it very important for us to have an appropriate diagnosis earlier rather than later. So things like the SCN1A predictor are going to become very important for our patients as we find these types of pathogenic variants. The best targets are monogenic diseases that represent a haploinsufficiency because it actually gives us a good gene that we can play with. So we're not having to do gene replacement. We can actually just do modulation of how that gene is expressed. But there are risks associated with this. So if we, administer a medication that increases the expression of a gene, but you have a gain of function variant, that means we are probably also going to express the gain of function variants that you have. And so that's particularly problematic. And so we need to be able to tease out gain of function from loss of function. Some of these therapies may not be reversible. And so that actually increases the risk, right? If we do something wrong and it makes things worse and we can't take it away, we're just sort of stuck with that. So that is pretty risky. The long-term risks are not yet known. We think that most of these things are targeted specifically to the gene that we're looking at, but we know that in the best of all worlds, we see spillover and it impacts other organs, not just the brain. And we don't really know what those long-term risks are. And so, we're going to have to follow all of these kids very carefully. Our neuromuscular colleagues are working through this right now with their SMA patients. And so, fortunately, they're a little bit ahead of us, and hopefully we can learn from that, but definitely something we all need to keep an eye on. We may prolong life beyond what is currently known for the natural history, and we don't really know the impact of disease on other body systems. I think this is particularly true of SMA. In Dravet syndrome, we actually do have reports of people in their 50s and 60s, so I think we do have a good sense. We're starting to get a good sense of what our older population looks like with Dravet syndrome. Some genetic diseases have a different disease with loss of function and gain of function. So if we think about MECP2, with loss of function, we see Rett syndrome, and we also have MECP2 duplication syndrome, which is essentially gain of function or too much MECP2. It's kind of a Goldilocks syndrome, and so we have to be careful with that too. Our biggest approach is antisense oligonucleotides. There are numerous genes demonstrating nonsense mediated decay by poison exons, and this is something that we can leverage with ASOs. So this is an innovative strategy to inhibit the expression of these mediated decay exons. And this is also called targeted augmentation of nuclear gene output, or TANGO, which is a word you've probably used. I have to say, I still have to kind of walk through this to remind myself how this works. So in our typical wild type gene, it gets transcribed from DNA into pre-mRNA, and we see these non-mediated decay exons are in here. This pre-mRNA will get spliced, and sometimes that exon gets spliced out, and that goes on to develop protein. And sometimes that exon doesn't get spliced out, and that mRNA just gets degraded and doesn't turn into anything. So the idea behind the Tango ASO is actually binds to that non-mediated decay exon. And so that encourages that it gets spliced out all the time. And so we get increased productive mRNA leading to increased protein. And so that's really the idea behind this, is that we will increase the expression of SCN1A. This probably happens both with the good gene and with the gene with the pathogenic variant. But the pathogenic variant, our body has a way of recognizing it and can eliminate it in most cases. But this is why is a problem for gain of function because we would increase the expression of that gain of function and it wouldn't always be removed. Not all of it gets removed from the body. And so that potentially is a problem for gain of function variants. So Stoke, what used to be called STK001, which now is called, I'm going to try and say this, I'm still trying to learn it because I just named it, Zorevunersen, I think is how we're supposed to say it, Zorevunersen, has been in safety trials. So about 85% of patients with Dravet syndrome have SCN1A pathogenic variants resulting in haploinsufficiency. And so the idea is that this tango will bind to that NMDA and increase protein production. And you guys have probably seen this in the mouse model. It was amazing. For those of you who aren't familiar with the mouse model of Dravet syndrome, the mice begin having seizures usually around day 20, postnatal day 20. And the mice actually have a really high risk of SUDEP when they start having seizures. And so mortality drops off pretty quickly. So that by 30 days, we usually only have about 30% of mutated mice still living. And so what we saw in the mouse model, and this was done in Lori Isom's lab, is when the mice were treated, they actually started to look pretty similar to wild type. So we actually didn't see seizures and we didn't see SUDEP, and it was really amazing. Turns out children aren't mice and mice aren't children. Children are much more complicated than mice. And so we initially had to go through safety trials. 74% of 74 patients have been treated with doses anywhere from 10 milligrams to 70 milligrams. The dosing actually started with low dosing and then gradually increased as we saw the safety profile. The 94% had treatment emergent adverse events, things like post-LP syndrome, vomiting, seizures. 32% had adverse events related to study drug. And these in particular were CSF protein elevation, vomiting, and irritability. The CSF protein elevation has been pretty curious. It actually, some of the children have quite elevated proteins, but they seem to be asymptomatic from this. And we're continuing to watch this. We don't really know what this reflects. So we're watching it carefully. And this has been reported with other ASO therapies as well. I suspect that it probably has to do with increased protein production and disposal of some of that protein production. But we do want to make sure that it doesn't get so high that it actually starts causing symptoms. For the patients who are in the safety trial, as they've gone up on the dose, we have patients who've been receiving 30 milligrams and 45 milligrams, and then we have a handful of patients who received 70 milligrams as their initiating dose. And we can see that we have a significant reduction in seizures, particularly in those patients who receive the higher dose of the medication, the 70 milligram cohort, which is probably what the recommended treatment will be in the long run if this continues to be successful. And this is what we're moving into with the efficacy trial, is dosing with 70 milligrams. So we can see that these patients have had, 75% reduction in seizures. But even the patients who were treated with lower doses of 30 milligrams, we can see that they've had reduction in seizures, as well as patients with 45 milligrams have also had significant reduction of seizures. It's important to keep in mind that the numbers are very, very small for these patients, and this was not designed as an efficacy study. This is really designed as a safety study. We are just moving into the efficacy study, and first enrollment in the efficacy study, I believe, will be in April, and will be pretty competitive and fast enrollment. So more to come for this particular product. The other mechanism that we have for treatment is AAV administration. So this is adeno-associated virus vectors that will administer gene modulatory therapies. We're not able to actually directly administer SCN1A to the brain with this way in this way because the gene is just simply too large. Although there are some companies out there that are looking at a way to disassemble and reassemble SCN1A. So I think there's a lot of technology out there that we're still working through the science of it, but it's pretty exciting. We have good delivery with AAV to the brain. The challenge is that we can only give a single dose of an AAV vector administered compound because we see an immune response. So when you go to administer using this virus vector a second time, your body will mount an immune response to it, and you won't be able to deliver it where you need it. We also see spillover into other organs, even if we administer directly into CSF. So as I mentioned, SCN1A is a large gene. It doesn't really fit into an adenovirus vector. And the gene also needs to be targeted to these GABAergic interneurons. So things that people are working through with the challenges. Encoded Therapeutics does have a product which is currently in safety trials, and I think they've dosed 3 or 4 children now. This is actually an engineered transcription factor that potently and specifically upregulates SCN1A. It's highly conserved, a human regulatory sequences that it binds to specifically in these GABAergic inhibitory interneurons. So this is a single dose of medication that will bind specifically to upregulate SCN1A, and once it's there, it stays there. So it's a one-shot dose. It's a single infusion into the cerebral spinal fluid, and in mice, we again saw significant improvement. Again, mice are not children and children aren't mice, so we really need to see what this looks like. They've also done non-human primate studies, also looking very promising. So this is actually administered in the OR into the CSF. So it actually is administered closer to the brainstem than in the spinal column, and so is a little bit tricky to administer. And so we'll have to wait and see. So lots of therapies coming in the future. Hopefully this talk will be way more exciting in 2 or 3 years. So I just want to switch gears a little bit here and talk about transition. But to think about transition, I think it's really important to recognize that children with Dravet syndrome do require multidisciplinary care. We've talked about gait abnormalities, the potential of Parkinsonism, cognitive and behavioral issues, of course, seizures, appetite and feeding issues. I do not place G-tubes. I'm not the best nutritionist, so we need help there. Some of the children do rarely have endocrine abnormalities, which I didn't talk too much about today, and then sleep disturbances. Here at our center, we actually have a child neurologist who specializes in sleep, who will see a number of my patients, but she actually lives in the pulmonary section, not in the neurology section. So there's a lot of multidisciplinary care that patients with Dravet syndrome need and require. And so this can be really tricky as we think about transfer. And it's also really complicated for families when we think about transfer. There's a lot of things that are involved in the transition of care before the transfer of care actually happens. And I think it's important to kind of keep this in mind when we're talking to our families. From a patient health perspective, things do tend to be relatively stable around the time that we think about transition and transfer of care. But as children are emerging into adults, they start having medical issues that, as pediatricians, we may not be the best people to understand. At the healthcare system level, that's when the actual transfer happens. And that can be really difficult for families because our pediatric approach to care is very different than the adult approach to care. And the buildings look different. They work differently. They are not as kid-friendly. Yet we have a 21-year-old who kind of functions like a 4 or 5-year-old who may be walking into that adult building. And so that can be really challenging. Parental life may start to become challenging around this time. Families are trying to wrap their head around, moving from raising a child to sustaining an adult and dealing with their own aging and health issues as well. And there's a lot going on from a legal standpoint. Age 18 is when our patients with Dravet syndrome become legal adults. And so many families do need to move toward legal guardianship, if not power of attorney. And that can be very challenging. And, many states have made this process a little bit easier, but there's still legal hoops that families have to jump through, so that only the appropriate people are obtaining guardianship that need guardianship. From an insurance perspective, things change with Medicaid and Medicare. And then there's also issues of around age 26 if people are going to come off of their parents' insurance or not. So a lot going on there. And then from an educational standpoint, high school graduation traditionally occurs at around age 18. Most of our patients will stay in the school system until they're 21, but then there's the issue of what happens after that, and are they able to get into an adult day program, or do they want to participate in an adult day program? And these kids do tend to be very social kids, so what is their day going to look like, and who's going to manage them when they require 24/7 supervision? So there's really a whole host of things that are happening around this time of transition and transfer that we need to keep in mind and be respectful of, more than just our little piece of it, which is transfer of care to an adult neurologist. And so I think it's really important that we plan to prepare families for transition. In our practice, we start talking to families about this around 14, just so that they know this is up and coming, and we continue to talk to them about it as we walk through that process. It's really important that we've identified providers that are willing to accept care of the family. And what we quickly realized here in Colorado is that our adult colleagues actually didn't have any patients with Dravet syndrome in their practice. That was partly my problem. I was holding on to 20 and 30-year-olds in my practice because I didn't have somebody to transition them to. And so I really had to work with our adult providers to educate them about Dravet syndrome and be willing to be there to support them so that we could transfer these patients to them. Um, most of these patients have multidisciplinary care, and so it's really important that we transition all of their care around the same time, but we can't do it all in the same month. It really needs to be more of a stepwise um, uh, process so that all of the care is gradually transitioned. But when you're in the midst of that, one of the big questions comes up is, where's the patient admitted during this process? So if you've transferred your neurologic care, but you haven't transferred your PCP or your pulmonary care, when you get sick, do you come to the children's hospital or do you come to the adult hospital? And so we actually have a bigger transition program that is working on that, so that we can have clear recommendations for our families as we transition through this. We generally now try to transition our primary care followed by our subspecialty care after that, so that we can say your admission will now happen over in the adult hospital because that's where your PCP is. It's also important to recognize insurance limitations. We have some patients where their family insurance is on an HMO, and so they may not be able to transfer to our academic center. We may need to find a neurologist within their insurance limitations, and making sure that we provide support for that neurologist. I think it's become very, very clear to me that solutions for transition actually have to be local. While I think that there is a lot of national work that's going on that is really important and really helpful for us all to think about transition and transfer of care, all of the solutions are local for our patients. And we need to make sure that we're thinking about this and that we're developing programs that'll be effective to make this happen. So I'm going to wrap up here, and I think we have a little bit of time for questions. But just the take-home points are, early diagnosis is important and will probably become even more important as we move forward with gene modulatory therapies. But when we have early diagnosis, it means that we can avoid contraindicated medications and we can start appropriate medications earlier. And that really will hopefully help improve some of the cognitive outcomes in our patients. We always need to balance seizure freedom with quality of life. And there are lots of other comorbidities associated with Dravet syndrome. And so it really does take a village to take care of these patients. And I do think that there's huge hope in gene modulatory therapies, but there's a lot of things that we have to work through to get there. So in the meantime, we need to be able to focus on all of the support that our families need and, again, balancing that seizure freedom and quality of life. And I will end here with a picture of Colorado, and hopefully we'll make it up that mountain. And I think we can open up for questions.
Excellent talk, Kelly. As always, always learn something new there. So it's great. You're an excellent resource for this. I know that I had a question. So one of my questions that kind of comes up is, some of the newer medications are fairly expensive, and
Yeah.
getting them approved can be challenging. Um, if you kind of have a choice, fenfluramine versus stiripentol plus clobazam, which one do you generally kind of fight more to get started early?
It depends on the age, to be honest. So, I mean, if we could take cost and insurance out of it, I probably would start fenfluramine. It is not approved for children under the age of 2, but I like kids to be on as few meds as they need to be. And so I would think more about fenfluramine because it's a single medication as opposed to the combination of stiripentol and clobazam, which is two medications. But my experience is that we cannot get fenfluramine approved under the age of 2. And so I think you are left with stiripentol and clobazam. I think the one thing that hasn't been studied as well between the two is, stiripentol in my clinical experience has worked really, really well in stopping episodes of status. What I usually tell families is that, we don't expect seizure freedom with stiripentol, but I expect to see fewer to no episodes of status when you're on stiripentol. And I don't know that we can say that for sure with fenfluramine. Part of that is that we see so many episodes of status in kids under the age of 2, and we're not really allowed to use it under the age of 2. So I think that makes it a little bit tricky. Um, I think, this is true for all of our patients, not just patients with Dravet syndrome. The cost of these medications is so crazy expensive and prohibitive. And, the vast majority of these kids are on Medicaid. And I think all of our states are managing this in different ways. And, the history of the gene modulatory therapies that are out there right now is that they are crazy expensive. And so I don't know what this is going to do to our Medicaid patients. I don't know how we're going to be able to pay for these therapies at the going price now. But I'm hoping somebody who has a stronger history and advocacy is going to be able to help us figure this out.
Always a question. One
Yeah.
other question I had is, I like the idea of the early genetic testing for patients who may fall in this category. What about is your thought about newborn screening? Since it seems like the earlier the diagnosis is, the better the kids may do, and you get them started on more targeted therapy.
Yeah. Yeah. I think we're going to need some research in this area because I think that we do see SCN1A variants that are not associated with seizures. And so, I think, it would be really nice to do newborn screening so we know exactly who's going, who to treat with gene modulatory therapies and who not to. And in an ideal world and in the mouse models, they're treating before that first seizure. But I think that we don't fully understand SCN1A variants in the patient population yet. And I think we're not great at predicting. We're getting better at predicting, but we're not perfect at predicting. And I think the last thing we want to do is give somebody a $5 million gene therapy treatment that they don't need. So I think this is an area that we really need to start researching sooner rather than later so that we can wrap our head around this a little bit better, so that we can think about newborn screening in the future. But as an example, I have a set of siblings who both have the same SCN1A variant. One who has, horrible textbook, straightforward Dravet syndrome, and the other one had two febrile seizures. They both had the exact same variant. And so you wouldn't, how do you know until you have some evolution of the disease, which one you should treat with gene therapies and which one you shouldn't?
So that's tough.
Yeah.
I don't know if anybody else had any questions. It's kind of getting beyond the hour there. Okay. Kelly, I really appreciate the time. It's great seeing you. Hope to see you soon at
Yeah,
AES.
absolutely. Absolutely. Thanks for inviting me.
All right. Bye.